Okay, guys, like Dr. Usma said, is there anyone who is going for this November OSCE and who is aiming for, in fact? I know the seats haven't been, confirmed yet. So, I mean, who is aiming for November OSCE this time? Hmm?
Ma'am, good morning,
Mhm.
ma'am.
Hi,
I'm
good morning.
trying for booking, ma'am. Still, it is not finished, ma'am.
Oh,
My,
part three?
yes, ma'am. My sister's son, he is trying with his credit card, ma'am.
Uh-huh, uh-huh. Why? I think the booking is open for India face to face and booking is open for UK as well. Hmm?
Yes, ma'am. He is having some difficulty. He is doing it, ma'am.
Okay, I hope you get it. I hope you get it.
Thank you, ma'am.
Okay, okay, sweetheart. Okay. So Zakia is going, Rabia or Rabia. Yes, that's very great. So, okay, that's good. Okay.
Okay, Zip, 1 minute. Can you just stop sharing? Then I will try to share again.
Okay,
One
fine.
person can share at one time.
Yes. Sure.
Okay, she said made me co-host. No, again, it is coming same. I don't know, some problem. Anyways, you display the PPT and we'll continue from there, okay?
Okay. Okay, yes, Dr. Usma.
All right. So please, can we start the session, guys? You all are there, ready? Open your mic and talk.
Hello, good morning. Good afternoon, sorry.
Good afternoon. Yes.
Dr. Tuhama. I didn't hear the question that before that all of you will sit for the exam, or what is the question exactly? The net is very bad here.
I was just confirming that how many of you are planning to sit for the November exam?
I already applied, but I'm waiting for the acceptance. No acceptance yet.
Yeah, acceptance will come in the end only.
After
After the date is closed.
Yes.
Acceptance or the
but they apologized for me about 2 times before.
Oh, then the chances are high that you will get the seat this time. Okay.
Okay,
So,
inshallah.
yes. So inshallah. So try, preparation. Start your preparation. Okay. Don't just
Okay.
like lose your strings in that, because for me, of course, for me also, I had the 2-3 times rejection. Then I got it all of a sudden. Okay.
No,
So you will get it. You will get, and I got it for almost, I think 28 days exactly before exam. And yeah, it was very, the cumbersome for me to apply for visa, and I got visa almost 5 days before exam. Then I traveled to
it's
Dublin.
good this time. It is Amman, and Amman is okay for
Yes,
Safa
Amman
for
is
me.
okay. Yeah, Amman is okay. Let's see, inshallah.
That's it.
Okay,
Inshallah.
okay.
Thank you.
Okay.
Yes,
The thing is, MRCPI people, even 2 weeks before the exam, they can, offer you a seat. So if you're planning to travel, keep your visas ready and continue your preparation, because we never know when this college will tell you that somebody has cancelled, so we are offering you a place in the exam. So stay prepared if you really want to finish this exam, because for us, we passed, I think, written exam in 2018.
18, yes.
Then we got the chance in 2021 November. So just imagine the wait, long 3 years of waiting.
Yes. So just, keep preparing for it. Don't just lose your strings. Don't just think that you just have to sit and wait for the confirmatory booking and then you have to go for exam, because MRCPI OSCE is kind of a surprise, a surprise package all the time. So you will get a surprise, you will get your booking, then and just, let me tell you guys this thing, that visa takes, pretty long for Ireland. Okay. So if somebody is aiming for Ireland, Dublin, so it takes almost, the exactly 1 month or 1 month and few days. Okay. And there is no urgent category. So you just have to apply as such. And if this time this is Oman as well. For Pakistan, I think this is little bit tricky for Oman too. So the candidates who are aiming for from Pakistan, so please make sure that you have somebody to invite you from Oman. Okay, until unless you have an invitation letter, you cannot apply for any visa. Okay, so make sure that you have all these things prepared ahead of time when your booking will start. Okay, so yes, nowadays it is never. I had to attend a conference from Pakistan for Oman, so I didn't get visa. Okay, and that was back in 2018 even. So Oman never gives visa to Pakistan. So make sure that, but they do give if somebody, I mean, who is residing in Oman and who can give you. Oh yeah, this is good for you. Okay, this is good for you that you are GCC resident. But I mean, for the candidate who are aiming from Pakistan for Oman especially, so you have to have invitation letter from there, the GCC resident or the anyone who is there, the working there or having a the PR and whatever. Okay, so in that situation, you can get visa easily. This is what I know, but still, you have to confirm it. You have to confirm it. So make sure you have all the knowledge before applying for any center you want to go for, be it Oman or be it the Ireland Dublin. So for me, I think the Dublin was very good. Okay, even though the things were very cumbersome from the beginning, but somehow I found it very good. Maybe from the MRCG experience that I had traveled to UK at that time as well. So maybe I found it good for myself. Yeah. So make sure you guys, they start your preparation for visa from now onwards. Okay. And I don't think that it costs that much. So because one visa will be enough for at least, the few, the months or few days. So if you guys can start from October. So I think by the end of, because usually RCOD, this MRCPI OSCE is by the end of November, 20th November. Okay. Whichever you want to choose is better. Okay. I don't want to comment on that because the exam is quite fair and the people do fail from Ireland as well. People do pass from Oman or any of the overseas the center as well. So there is it is all about how prepared you are for exam, how good you are in exam. So it all depends upon your performance. Okay, it doesn't depend on the center, mind it. Okay, so never believe if somebody is telling you that, okay, that center has high result, that center has high result. No, I don't believe in that. What do you think, Dr. Uzma? Isn't it?
Yeah, this is very right. You see, I don't want to say this, but the thing is, the candidates who fail, they try to find out the problems
Reasons.
not with themselves, either with the place where the exam was conducted or with the examiner. So nobody knows you, nobody wants to fail you. It is only you who will pass yourself or make yourself fail. So your preparation is the most important thing. Center, place, examiner, they are not relevant. If you perform well, if you know the topic, you will pass wherever you will sit for the exam. So that is the main thing. Always remember that. Don't try to find out excuses for your failure in somebody else. It is only you. If you are working hard, if you are well prepared, if you have practiced enough, you will definitely pass. Believe you me, these MRCPI examiners are very soft spoken. They are very fair. Wherever you will sit for the exam, either Ireland, because I sat in Dubai, everything was, maybe 2 examiners came from Ireland, others were from here and there, UAE, and they were very, very fair. They were not trying to drag you or distract you or insult you, nothing. They are very fair, and if you have the knowledge, you pass the exam. It's very simple. There is nothing else in the exam. Okay, I think we'll start.
Yes,
So
yes,
first of
Dr. Uzma.
all, thanks all of you for joining in our session. And congratulations for passing the written exam. I know that you all have the background knowledge, and that is why you were able to pass. It is a difficult exam, and it's great that you have passed. And I'm sure that if you prepare yourself well, you will pass the OSCE in first go, inshallah.
Inshallah.
So the OSCE, can we have the second slide?
Yes, 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 yes.
Yeah, so as you know, the part 2 OSCE, it is a clinical exam which consists of an OSCE and a clinical exam. So you have 7 stations which are each for 10 minutes. And in this, your knowledge is tested, understanding of obstetric and gynecology, as well as they test your problem solving skills, your diagnosis, investigation, treatment, clinical and communication skills. and there is one long case. So that long case, you have 25 minutes to do that long case, and there are two examiners sitting for that long case. It is fully observed, that long case. Since COVID era, this is not done in a hospital setting. Even if it is in hospital setting, the role player is there instead of a real patient. So you will be taking your history from a role player. This is, I'm talking about the long case, okay? So you will take your history from the role player. You have 25 minutes to perform the task. So once you finish your 10 minutes, somebody will knock on the door and tell you that 10 minutes have gone. Now it's up to you. You want to continue talking for 25 minutes with the patient, or you want to finish everything. So in that 25 minutes, what they expect from you is to take a complete detailed history from the patient. Okay. And then they say, okay, once you finish your history with the patient, you go and perform the examination. Examination is on the mannequin. Mannequin, if it is a gynae case, normally only the lower part pelvis area is there. If it is an obstetric case, then full dummy will be there. So they ask you to say what you will do in the general physical examination. So of course you will not perform something on a mannequin, but you have to verbalize everything starting from head to toe, how you will do a general physical examination. So that all will be verbal. Then for the obstetric examination, they expect you to perform all the maneuver like abdominal examination, palpation, how you will do the height of fundus, liker, and all your pole maneuver they expect you to do in an obstetric examination. And if it is a gynae case, then you will do inspection, you will do speculum examination. They will keep a pap smear as well there. If a pap smear is required, they will ask you to take a pap smear of the dummy, and the PV examination. While you are performing in the examination, you have to, keep talking what you are looking for. Any particular case, suppose a patient is with postmenopausal bleeding. So if she is, you have to talk that I have to exclude atrophic vaginitis, any growth on the cervix. So, all these things you have to keep verbalizing, and same time you will keep performing the thing on the mannequin. Once you are done with your examination, and please don't forget to, wear gloves, do the hand sanitizing technique. They're observing everything, and keep your folds, your sleeves folded above the elbows. These all things are very, very important. There are marks for it. So, and once the patient is going to the bed for examination, make sure that you ask the patient that I will examine patient in the presence of chaperone with her consent. I will ask her to pass urine before we proceed for the examination. That is very important. Otherwise, a full bladder will give you a wrong height of fundus. You have to verbalize these things just to make the examiner understand that you have the background knowledge. Okay, am I clear so far? Any questions? No question?
No question is a good question.
Either you don't understand anything
or either you understand everything. It's either way.
Great. So once you finish with your history and examination, then they will tell you to summarize the case. Two examiners who were sitting and observing you, so they will tell you to summarize the case. You will summarize the case, and then they will say, okay, what is your diagnosis? What is your differential diagnosis? How you are going to manage this case? What will be your follow-up plan? Yes, please, Shumaila, open your mic and ask.
Yeah, Dr. Assalamu alaikum. How are you?
Walaikum assalam, alhamdulillah.
Yeah, my question is that regarding the gynae cases, we will not do general physical examination, or we will just tell them while performing the PA or the PV or speculum, whatever, how we will proceed in case of gynae.
You see, I had a gynae case. My case was postmenopausal bleeding, and only the pelvis was there. So there was no abdomen, no rest of the mannequin was not there. So where you will perform you only have to verbalize in this case that you will look for this in the general examination, this in the abdominal examination, and now I will perform the gynae examination in front of you.
Okay, so before starting the gynae examination, I will verbalize about the general physical and systemic examination, and then I will proceed for the performance of gyne examination, right, doctor?
Exactly.
Exactly.
Okay, and in obstetric, you just mentioned that there will be abdomen and there will be face also. So we'll go for
Yes.
the general physical examination. And
Yeah,
only I will verbalize about the vitals that after general physical, looking for the anemia, signs of cyanosis, and hydration status and thyroid, whether it is enlarged or not, I will proceed for vital monitoring, pulse, blood pressure, temperature, respiratory rate, and SpO2 at room air. This is like I will say.
Yeah, Shumaila, actually you start with the vitals first and then you proceed with the general look of the patient. Okay, so you always
Okay.
start at, okay, I will see the gait of the patient, how she walks to the couch. If she's comfortable at rest, oriented in time, space, and person, I will go through her vital signs, including her blood pressure, pulse, temperature, oxygen saturation, and respiratory rate. Then you proceed with the anemia, clubbing, and knee swelling in the anterior part of the neck, breast, if they are symmetrical, or the nipples are inverted, if any discharge from the nipples, then I will auscultate for the heart, then I will go to the abdomen. I will also look for the lung, any added sound in the lung, and then I will go to the abdomen. There will be inspection, overlying skin is normal, umbilicus is centrally placed, moves with respiration, any stria gravidarum, any linea nigra, any scar of previous surgery. Then I will proceed with palpation. I will start with the non-tender area, and then I will look for any tenderness, guarding, rigidity, if any mass is palpable, any organomegaly is there. And then if there is a fetus inside, like you have to perform the height of fundus, lie of the baby, and longitudinal or presenting part, and then I will look for any auscultation if required, like fetal heart sound you need to. So no, this is how you proceed.
And then about the legs for any calf tenderness and
Yeah.
peripheral pulses, right, doctor?
No
Yes.
peripheral
Thank you so
pulses.
much.
They
No
just want
peripheral
you to
pulses.
say that if there is any edema or no.
Okay. Okay. Thank you so much.
No problem. No problem. Okay. So once you are done with all this examination, your discussion, they will discuss with you your plan of management and follow-up plan. And then, halas, you are done with your long case. Okay. The long case can be either a obstetric case or it can be a gynae case, anything. So stay
Here I want
prepared.
to add one thing, because in the long case, what you will have is that most of the time you will have a role player. So in the first 6 to 7 minutes, you will take history from the role player by seeing your task, what your task is. And then examiner will ask you that, do you need any kind of investigations? So, after taking history, you will proceed to examination. You will be taken to the dummy. If at all it is present there, then you will do the examination on the dummy. Like Dr. Uzma explained everything about that first you have to verbalize and then you have to do the examination on dummy. Then you will come again and sit back and then you will say that, okay, then examiner will ask you summarize your case. Then you have to summarize your case, okay, in the lines of what history you took. And always remember, in summarizing the case, you just have to utter the positive findings, okay, the positive findings from the history, from the examination. Then examiner will ask you, what is your probable diagnosis? So you will say that, keeping in view of this history and examination, my probable diagnosis is this. Okay. So then he will ask you that, do you need any investigation? Or you would say that to supplement this diagnosis, I need further investigations. Okay. So if you will say the investigations, then examiner will show you the investigations. Okay. Then you will quickly have a look at the end. This whole rehearsal is going to be for 20 to 25 minutes. Okay. Long case is for 25 minutes. So you have to, be quick. 5 to 6 minutes in history, 5 to 6 minutes in examination. Then, the both examiner will do the discussion with you. For example, if you are taking 12 minutes over here, you are left with almost, the how many minutes? 17 minutes or the 13 minutes later. Okay. So in 13 minutes, you have to, if you think that you have to counsel the lady there and then again, okay, so you will immediately look at the patient, and then you will say that, okay, that in the layman language, that, okay, you will be having the this, and we will be doing this if at all time allows. Then in the next, because you are facing two examiners, so both examiners, the first examiner will ask from the summary of the case, you need an investigation. Second examiner will discuss. He will ask you that, okay, now tell me how you will manage this case. Okay, so this is how the long case will go. It is going to be a kind of progressive. At all times you have to have your senses intact. because this is going to be a long haul, and you will be, the overhearing, the so many, because I have been in Dublin. So in Dublin, it was a long haul, and there were like, I mean, 4 or 5, the bunch of, the examiners who were sitting, okay, and we were having, the the exam. So of course, you will have either ops case, or you will either have, the gynae case. So I mean, you have to be prepared for all type of cases there is, okay. So don't think that this exam is very easy, like, many people say that this is very easy exam and you will just go and you will just pass. No, every exam needs preparation. Every exam has a different, the criteria for the markings. Every exam has different, the positive points. Like Dr. Uzma told you, that if you are not fulfilling the, the criteria of confidentiality of the patient, if you are not giving her due respect, well, even if you are verbalizing that, okay, I will, I mean, in terms of examination, so how much area you need to be exposed, then you have to cover it. Because in my exam, what happened was, there was a mannequin and it was, covered with, the piece of cloth. So of course, I was, just speaking to the examiner, and then I was, the doing that, okay, I will, the expose the woman up till here, whatever I needed at that time, because I had ops case. So of course, but I will not, expose the breast, because I have to, the keep the dignity and the keep the, privacy of the patient as well. So I will just expose this, the abdominal area, to perform the per-abdominal examination. Then he asked me, okay, how you will do the per-abdominal examination? So of course, before that, you need to understand that how you are going to do the per-abdominal examination. And I think this is a separate, the class. But of course, you have to have this clear, the knowledge. On my day, I had, this ops case, and one of my friends, she had gynae case. So she had, the one pelvis and, the examination. So they asked that how you will do the bimanual examination. What exactly would you see in this case, that if you will do bimanual exam, if you will do per speculum exam, if you will do, if you want to take any swab, so which of the swab you will take. So, this is how long case goes. So it's not like that they will ask you typically that, okay, from here, it is going to be a progressive case. Okay, so now a patient is this. So now a patient has come for this, what you will do. Now patient has developed this, what you will do. Okay, so make sure that you train yourself. Your reflexes should be like this, that how you are behaving. For Irish exam, basically what I have observed so far is that they really focus on patient centered approach. They are not so much into guidelines, or they are not so much into, the theoretical stuff. Rather, they really want to focus on patients. Okay, am I right, Dr. Uzma?
Yeah, I think, Zaib, they are not only focusing on how you approach your patient, but they are also concerned, especially you will realize this thing in the OSCE stations, where your applied knowledge is very, very important.
Exactly.
So there they expect you to know your theory very well. So that's why in MRCOG, maybe you can get away with communication here and there, you will get some marks. But in MRCPI OSCE stations, your applied knowledge should be very, very strong.
Exactly. Exactly. Okay, so it is going to be like there. Likewise, this is going to be a very patient-centered approach. Everything with regard to this particular patient, everything with regard to this particular patient.
Yes, you can ask the question, please. Open your mic.
Okay, Assalamu alaikum, doctor.
Walaikum
May I ask for this long case, is there possible to ask us to do forceps delivery, or how to apply vacuum, or to do some like this, or only obstetric examination or gyne examination?
See, Nahid, that application of forceps or vacuum delivery, that is a separate station. They will not ask you to do all this in long case. Long case, the idea of the long case is your detailed history. If you are able to take a proper history from the patient, you are able to reach a diagnosis, how you will investigate that certain case, whatever is given to you, how you will manage at that time, and then what will be your follow-up plan. So this is what the theme behind the long case is. This application of forceps, kiwi vacuum, shoulder dystocia, They say that they might put as a OSCE station, but practically speaking, there are so many candidates, they don't have all this number of instruments and things available, so they normally don't put such stations. But
Thank you.
still, you have to stay prepared for it. Okay.
Like only theoretically, and I will mention the steps like this, but I will not
Yes, you will
do this.
mention the steps.
Or I will not do it because here in Saudi Arabia, I did not see this forceps at all. Really,
Yeah,
only by studying this one, but we are not applying this one.
Yeah, Naid, the thing is, that's what I'm saying, because they will not provide so many forceps there, no? Most likely it will not be a hospital-based exam. It will be somewhere close to the hospital or some conference room. And maximum what they will bring is a kiwi vacuum, which is a small thing. So
Yes.
maybe kiwi vacuum you're applying. So most likely it will be, if it will come at all, it will be all verbal. So you should know your steps, how you will perform. I don't think they will bring the baby and, make you apply, because there is no teaching station in MRCPI.
No,
Okay.
not like MRCOG. There's
Yeah,
teaching.
no, not like MRCOG.
Okay, thank you, doctor, so much.
No problem. And the other thing which is very important is they don't provide you with detailed history in the station. There are only 2-3 lines written there. Name of the patient might be written, age will be written, and her main complaint. Rest of the history you have to take from the patient. Okay.
Yes.
Okay, so not in detail. So we will counsel the patient and we will know what's her problem, and then we will make detailed history. Then we will make summary for the examiner.
Exactly. And what they want from you is that my examiner, once I finish the history, because then you have to, it is best to be on the safe side to ask, is there anything that I missed or would you like to add? Then, patient will say, what do you mean? Any investigations done for you? Then even the investigations, they are not providing you on the table. Only if you ask for it, they will give you. Okay. So then, and once I finished the history, I said, can I summarize the case? He said, no, you will not talk about the case to the patient. Let's go for the examination. And then examination part was done, and then the discussion was with the examiner. In between, what they can do is, okay, so suppose your diagnosis is cancer of womb, endometrial hyperplasia, or endometrial cancer, ovarian cancer, something like that. They might ask you, okay, can you explain this to the patient? So they can bring in the patient again. It is all depends on the examiner who is sitting there. Sometimes they don't want you to talk back to the patient. Sometimes they will say, okay, how will you break this news to the patient? Like a breaking bad news thing like that.
Yes.
Understood?
Excuse me, doctor.
Yeah, sure, Shumaila.
My question is that first question is the difference between a role player station and long case. How to differentiate, because it is 10 minutes and history we are supposed to take, I think, for 3 minutes.
How to
If it
differentiate?
is
No. You will have either your OSCE stations first, okay, or and in the end you will have a break for like 10 to 20 minutes or 30 minutes, okay, and then you will have long case. So I mean it is very easy. So in 7 stations you might face the 1 or 2 role player station, and the other are going to be the structure discussion task. Okay. In the long case,
So-
of course, it will be a long table. There will be a patient, and there are going to be 2 examiners. So I mean it's very easy.
Okay. And regarding the stations, how I will know that in this patient I have to take history. Like if they
Everything
simply
will
say,
be in
okay,
front of
tell us
you.
the management.
Everything will be in front of you. There will be a question. There will be a question paper or question. So of course, it's not like verbal exam. It is like MRCOG, but there are no cabins, and there are no the arrangements like RCOG, but it is the more or less similar like RCOG. Okay.
Okay, Shumaila,
Okay,
let
but
me just explain this. Wait, see, because Zaib went to Ireland, she can explain about Ireland. I appeared in Dubai. So if in Oman, suppose you are sitting in the exam in Oman, what they did in Dubai, First of all, because there is a time zone difference between UAE and Ireland. So our long cases started first here. So they divided, there were 36 candidates. They divided us into two groups. So first 18 candidates, they went. There were different rooms. And inside the room, there was a table where the role player was sitting and two examiners are sitting behind the role player. The station is inside the room on that table. Okay, you don't get a separate time to read the station. You all 25 minutes you have is you will read the station in the same time and do the rest of the thing in that 25 minutes. Okay. So once after 10 minutes they will knock, after again 10 minutes they will knock, because they want you to know where how much time is left. So 25 minutes done, you will go from that room. Next candidate will come. So you will go out from there, and then there will be a waiting time, maybe sometimes 2 hours, 3 hours. Once they will start the OSCE in Ireland. Now the exam is for 2 days in Oman and only 1 day in Ireland. So day one, this will not happen. Once they finish with all the candidates long case, so they will go to the OSCE. So then OSCE again, they divide you into groups, and first group will come, 7 stations are there. There is no separate reading time. There is only a 2 minutes gap from one station to the other station, and there is one rest station. So once you finish your station, you go to the next station and you stand there for 2 minutes. Those 2 minutes are for the examiner to give marks to the previous candidate. Okay, this is not for you as reading or anything. So you just stand there, prepare yourself mentally, relax yourself, and go for the next station. And then 1, 2, 3, 4, 7, you finish, your exam is done. You go out of that exam hall. Understood, Chumaila?
Yes, thank you so much, doctor. And regarding these stations, and if the examiner asks, okay, how you manage the case, and I have to take history, and I have to briefly examine the patient or verbalize examination, then also I will shorten the history and I will shorten the examination.
No. The examination is only for the long case. The OSCE, only one role player station will be there in the OSCE. That will be communication skill they will be testing there. That can include breaking bad news, anything they can bring there. Okay, those out of those 7 OSCE stations. Only in the long case you have to take a detailed history and examine the patient. Other things, if there is any station, you will just briefly verbalize. There is no patient there. There is you and examiner. That's it.
Okay, doctor. Thank you.
Okay, I hope everybody is clear about the format of the exam.
Doctor, I have a question.
Yeah, please.
Okay. In a role player station, in MRCOG part 3, we are asking the permission from the patient to examine her in front of the chaperone. Here, the same we will do?
You will do the same, but you will say, I would like to examine the patient in the presence of chaperone with her consent. But the exam, because you have, the examiner has to know that you take care of these things, that you have to take permission from the patient, and you want somebody to stand there as a witness.
So we will tell only. We will tell only.
We will verbalize, yeah.
Yes, thank you. Thank you.
Okay.
Okay,
All right.
thank you.
Anything, Dr. Zaib, you would like to add?
No. That's it. That's all. I think.
Okay, so who would like to take the station? We will do one long case and one OSCE station. Okay, so 1 minute, Zaib, can you show me the previous slide? So
Yes.
as you know, the examination will be on Friday, 25th and 26th of November in Oman, and only 26th November in Dublin. So the applications are still open. Once they will close on 28th September, that time they will confirm who is, lucky person who got the seat in the exam. But still, they keep sending messages till maybe 2 weeks before, 1 week before. So anybody who is really interested, keep things ready for yourself. Okay.
Exactly.
Okay. So let's. Can I have one volunteer who would like to take the station, please?
Long case.
Come on, it's just a practice. Don't be scared. We have so many people. Shumaila, would you like to take it?
Okay, doctor, I will try.
Good, good. We are all learning. Don't worry about it. Okay, so before we start the long case, I will just briefly go through a few things. Previous slide.
Okay.
Okay, after the COVID restrictions. Yeah, so everybody has a template. So where you will ask for the name of the patient, if she is a resident of Ireland, and before the COVID era, they were doing the exam in the hospital setting where they were real patients. So you will ask from them that how long, when you were admitted, what was your complaint, what all is done for you in the hospital, and what is their plan, okay? There they will provide you all the reports and everything. Now, since it's a role player station, most likely this time also it will be a role player exam, not a real patient. So you have to have your own template where you will confirm the age of the patient, name of the patient, what is her complaint, what is the history of the complaint, how long has she been. You can ask the patient, but you can say that, okay, this is for the previous exam. Menstrual history, obstetric history. This is, I'm talking of gynae history, okay, not the obstetrics. And of course, in gynae history, these things are very important to discuss sexual and contraceptive history. Then past medical surgical history, you review the systems, you ask for social history, family history, any allergies, any drugs, and you summarize. Okay, this is how you go about the history. Your history should not be very, very long. And in the end, do close the station. Okay, thank the patient, summarize salient points, and your skills should be, you should be actively listening to the patient, summarizing, and signposting. Signposting means what? Any idea what signposting means?
No, doctor, no idea.
Signposting.
Yeah.
Yeah, please.
Sometimes we will ask some personal questions, so we will ask her permission. Like I will tell her, pardon me, to ask you if any recreational drugs, or sometimes I will ask her, may I ask you some intrusive question? It's about for sex sharing infection. Like this, I will ask. Yani, before I will ask the question, I will yani prepare the patient for the question.
Very well, very nice, Nahid. Yeah, this is what you do. And then something very important, suppose you have some bad news to break to the patient, then you will start with some things, no? Which I think all of us know that, okay, I can see that you're alone today. Would you like to call someone? Yes. Or would you, can my sister sit with you? I'm afraid I don't have a good news for you. So these are all shots. You're preparing the patient for something.
Yes.
Which is not pleasant, okay?
Yes.
All right. So general physical examination, then you will perform once you finish your history. Next slide, please. Yeah. So as I told earlier, that you will observe the general appearance of the patient, nutrition, gait, level of consciousness, how the patient is responding, height and weight. Then you assess for any stained fingers, clubbing, blood pressure, temperature, head and neck. If like PCO patient, you will talk about that. I will look at the hair distribution of the patient. Any facial hair is there. Then you look for the signs of anemia, jaundice, cyanosis, lymphadenopathy, any enlarged swelling in the neck and legs. You will look for any ankle swelling. Then you will go for the abdominal examination. Next slide. Yeah, after abdominal examination, you will go for the gyne examination. So abdominal, we all know this, that you will inspect, you will palpate, and if there is need of, there is a fetus inside, you will do auscultation of the fetal heart. Okay, then you will proceed with the gyne examination. Gyne examination will be speculum examination first. If there is a discharge, you will just keep talking that I will collect any swab. If there is a discharge, I will look at the cervix. There is a pap smear lying there. They might ask you to collect pap smear from the patient. And then you will perform a bimanual vaginal examination, and you will keep talking what you are looking for. Size of the uterus, if it is mobile, any tenderness there, any adnexal masses are there. And that's it. Okay. And of course, a postmenopausal woman, you have to speak that I want to look for any atrophic vaginitis as a cause of postmenopausal bleeding, which is the most common cause in a postmenopausal age. Okay.
Doctor, one question, please.
Yes, please.
If it is under 24 weeks, age of gestation is less than 24 weeks, then for the FHS, we'll confirm what I will say, that I will confirm by scan.
No, fetal Doppler, you can hear 24 weeks, right? 12 weeks you cannot hear, but 24 weeks for sure you can hear with the fetal Doppler, handheld Doppler.
So till which gestational age I will say that I will use a scan to confirm the FHS?
Only a 14, 16 weeks. After that, you can hear the fetal heart.
18 weeks onward, I will use that fetoscope, or they provide fetoscope or the Doppler?
That is a mannequin. Which sound you will hear from a mannequin? They will
But I
provide
have
you handheld Doppler. Not the nobody
Okay.
uses this fetoscope anymore.
Okay,
Okay.
right.
So they will provide you with that Doppler.
But I will say that if it is still 16 weeks, I will say that by scan, I will confirm the FHS.
Yeah, you can say that the patient is still in early pregnancy. So if I'm not able to hear the fetal heart with this handheld Doppler, then I might confirm it with the ultrasound. But the thing is, in UK and this Ireland, they don't perform the ultrasounds for stupid reasons. Okay, it only if it is required.
So that's what I want to know. Like, in which scenario I have to skip that I will not mention about FHS?
You know, your scenario will be very clear. Don't worry. They will not bring a 16-weeker and tell you to hear fetal heart for it. Okay. Once you are examining a patient, you will just say that since she is early pregnancy, I won't be able to hear the fetal heart. So I can confirm, because patient will not be feeling the fetal movement also till 5 months of pregnancy.
Yes.
Right. So you can say that, yeah, the fetal heart can be confirmed with ultrasound. But I won't be able to hear it with the fetal Doppler. That's it. Okay?
Okay.
All right. So I think let's go to the station. Okay, so Shumaila, your station will be for 25 minutes. In this 25 minutes, I expect you to take a history from the patient, okay? And the examiner once you are summarizing the case and doing case discussion, that time the examiner might ask you to explain things again to the patient. Okay. So I don't want you to go and explain everything to the patient and use maximum time there. You understand what I'm saying?
Yes, doctor.
Okay. All right. So let's start.
Hello, I'm Dr. Shumaila, one of the doctors in Gyne Clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Francesca Bulthorpe and I'm 32 years old.
How would you like me to address you?
Francesca is fine, doctor.
Well, Francesca, from your case notes, I have come to know that you have periods problem. Can you please tell me more about your issue?
Yes, doctor, I'm coming to my GP for quite some time because my periods are just not regular. Either they don't come, or if they come, they are so heavy, they don't stop. So I'm really bothered about my cycle. So that is why they told me that I had to go to Gyne and get myself checked. That's why I'm here.
Okay, and may I know your last menstrual period?
I think it was 3 weeks ago.
And for how much time how many days it lasted?
It was like 9 days, yeah.
And the flow was regular?
Yeah, it was heavy. I had a lot of bleeding in the first 5-6 days. And then I called my GP and he told me to take some medicine. So I took that and then the bleeding became less.
How many pads did you use per day?
Maybe 10.
And any passage of clots?
Yeah.
All right. Do you experience any abdominal pain in your tummy or back?
Once I have my period, yeah, there is some discomfort, but otherwise, no.
Okay. And since how many months you are experiencing this complaint?
Oh, this is since long time, maybe 10 years now, but gradually this problem is increasing. As I'm gaining more weight, I feel my problem is increasing. Either I don't have a period or I have like this.
All right, Francisca, I would like to ask you a few more questions. Are you married?
No.
Okay. And do you have any visit to a GP for any medical conditions like hypertension, diabetes, clot, respiratory issue, or renal?
No, doctor, just because you seem I have a BMI of 48. So my GP sent me to see a dietitian to lose weight, and and I don't, otherwise, no other treatment. Though he keeps telling me that I will have everything, but at the moment I don't have anything.
Okay. And do you have any significant family history of any medical issue?
Yeah, my parents, they had diabetes and high blood pressure.
Okay. And did you have any surgery on your tummy or down below before?
No.
And I would like to ask you a few questions, which are very important for the management of your case. Do you smoke?
No.
Do you drink alcohol?
Socially, not really.
Do you use any recreational drugs?
No.
Are you allergic to any medicine?
No.
May I know your, do you live with your partner?
Yeah, I live with my boyfriend.
And is he supportive?
Yeah, he's good to me.
And what do you do for your living?
I work in a jail. I am this one jail guard.
Okay. And wait, high pressure is the one with MRI. Okay. And well, Francisca, I would like to do some basic blood tests for you and one ultrasound for having a proper establishing a proper management plan for you. And is it okay with you? We can proceed for the investigations.
Doctor, they already did investigation for me. I'll show you the scan and the results, okay?
All
Zaib,
right.
Zaib, can you, next slide, please? Hello, next slide. Where is Zaib? Wait, Shumaila.
Okay, dear.
Can I have next slide, please? My God. Where is Zaib?
Yes, sorry.
Okay. All right, this is the scan. Do you want the
Okay.
next slide?
Yes, please.
Next slide, please.
Is high. Oxygen is high. Okay, Francisca. Thank you for sharing investigations and ultrasound report with me. And I would like to examine you Is it okay with you?
Yes, no problem.
Okay, so since patient is not married, so I will only examine her per abdominally after general physical examination and systemic examination. How I will, so in this per abdominal examination, I will start with inspection and then palpation, superficial and deep palpation, and then percussion for any ascites, any dull note or resonant note, and auscultation for the bowel sounds only. And since she is not married, so I will not proceed for uh, bimanual examination or speculum examination. And
Shumaila, 1 minute. We
yes,
are
okay.
in Ireland. We are giving Irish exam. You are not supposed to be married. You are not, as it is not necessary to be married to be sexually active.
Okay, right. So,
Okay.
so I will do the bimanual examination for any palpable masses and any tenderness in the fornices, and whether the uterus is mobile or fixed, to assess the position of this first the speculum examination to look for the cervix, and whether any local pathology is there, any vaginal discharge, and then I will do the manual examination, and then I will present the case to examiner, to my consultant.
Okay. Summarize the case.
My patient Francisca, 32 years old, with the complaint of irregular periods. She's not married, living with her partner. Otherwise, no medical issues and no medical issues and irregular cycle since long time with a high BMI, 48, and she has no significant medical history or surgical history, no family history. Parents are, I forgot what history she's told me. She's not a smoker, occasional drinker, and not on any recreational drugs, not allergic to any medication, and her periods are last LMP is 3 weeks ago, and from her examination there is abdomen is soft, non-tender. On inspection, uterus is centrally placed. No scar line, no scar marks, no palpable masses, and no ascites. And bowel sounds are positive. And on a speculum examination, there is no abnormal vaginal discharge. Cervix is normal, and on bimanual, fornices clear, non-tender, and no fullness in the fornices. Uterus is 6 weeks sized, and from her investigations, it reports LH to FSH ratio is high, and the testosterone is also high. Endocrine AMH is also high, and she is she's with a normal thyroid profile, and prolactin is also normal, and ultrasound reports both ovaries with multiple follicles in the periphery. So my probable diagnosis is of the polycystic ovarian disease.
Okay, so what you will tell the patient, what she has?
I will tell the patient that she is having polycystic ovarian disease, and for that reason she's having irregular cycles for long, and she has to go for the lifestyle modification, which is the first line treatment. She has to do the weight reduction and exercise, and she has already been she has already visited the dietitian, but she has to review her dietary plan, and then since
What
she
is
is
her
with
option if she is not losing weight with the diet nutritionist and exercise?
then she has to go for the medical management that includes use of medication to, since her insulin is also, fasting insulin is also high. So she has to use medication to control. We will prescribe her medication to control that. And also
Which medication?
for this, we'll offer her metformin.
Anything else?
And metformin, and actually I'm not prepared for this.
It's okay, no problem. Okay, then
If it is not resolved, she might have to go for laparoscopy and ovarian drilling. That is a surgical procedure.
wait, Shumaila. So after lifestyle modification, you will directly go to laparoscopy?
No. After the medical management with the metformin and the what we will give, we will give her hormonal treatment.
What are the possible long-term complications of PCO?
She can have diabetes
What else?
and subfertility.
Okay. And
diabetes, subfertility, hypertension also, because she is obese, 48 BMI, obese, third, it is like in class 3 obesity.
okay. So what you will tell her, lifestyle modification and weight reduction. And then if she needs treatment for fertility, how you can do that?
Fertility treatment, I will first we will regularize her menstrual cycle.
How you will regularize?
By giving her the progaluton.
What is progaluton?
Hormones, estrogen and progesterone.
Okay.
Then? And this for infertility, we are giving this HCG, FSH, but I don't know how to tell because I did not go through
fine.
this.
Okay, so all right. So, do you know if this patients with PCO, if they get pregnant, what are the possible complications they will have?
PCO patient, if they get pregnant, may have miscarriage and because of diabetes, there could be a macrosomic baby, difficult delivery. Sorry, doctor.
No, it's fine. It's fine. Okay. Anything else you want to add? Because we still have almost 10 minutes.
PCO, regarding subfertility, you asked tubal patency. We have to check, and her screening of the partners regarding semen analysis, whether that would be the initial investigation before starting treatment for subfertility. Though the patient is diagnosed as polycystic, but the partner's evaluation is also important regarding subfertility. And then I will tell the patient for preconception use of the folic acid, 5 milligrams daily, and also for the
okay, it's fine, Shumaila. I think it's okay. Thank you very much. You at least you came forward and you tried to attempt, though you were not prepared for the station. Still, you tried. That's very good. And only if you try, then you will know, you will have the confidence of facing the examiner, and you will find out your mistakes only once you perform station. Just listening to others, it's very easy to find out mistakes in other person's performance. Once you are on the stage, how you are doing it, that only you will know once you are in those shoes. So thank you, Shamaila.
Yes, yes, very brave attempt, Shumaila. Very good.
Thank you, doctor. Thank you.
Okay, so anybody want to talk about PCO, how you will manage a patient with PCO?
Ma'am, Doctor?
Who's this? Yes, Nahid.
Assalamu alaikum, Doctor.
Alaikum.
May I tell something? Because in the history, we did not ask the patient about if she is removing the hair more frequently, if she has any contraceptive before, if she has been pregnant before, any cervical screening done. So we have to counsel more about the patient, I think so. I think
Yeah, you are very right, Nahid. Actually, what problem happened? Shumaila asked me if I'm married or no. This is a very wrong question to ask from a patient.
we cannot tell. We will ask
You
if she is
cannot. Are you with the?
sexually,
Are you
if she is
sexually
sexually
active?
active, if
Yeah.
she is
Are
living
you
with a
living
partner.
with someone? This is
Yes.
the question. Not
Yes.
you are married. And once she thought like you are in Pakistan, if you are not married, alas, you will not have sex. So she removed all that part.
No, we will ask more if she tried contraceptive before, any treatment she took before. She has 10 years history. So actually of course she tried some medication. We will ask more if she took any medication. We will ask about her if she is removing hair so frequently, about her high BMI. It is not and this is 46. We will ask her if she try any medication, because sometimes they are taking less oral stat or something. We will ask more about these details, and we will ask if she has this cervical screening before, if there is any sex sharing problem, because irregular period, it's not only PCO before. Yani we are not at the beginning. We will take detailed history.
Yeah, you're right, Nahid. Anyway, it's fine. This is for the first time, and it is unknown station for her. It is not something she practiced and she performed. So only with practice, these are the valid points which you should cover in your history. So I think we'll go to the station. I will just explain you how you perform the station. So Shumaila, once you are taking a history, you see once in the history, she's 32 years old. Okay, so in UK and this Irish exam, you never ask the patient that are you married or no. Okay, so who you are living with? Okay, your partner. Is he supportive or is she supportive? I can be living with my girlfriend of mine because I may be in the same sex relationship. So, your mind should think according to the place of exam where you are appearing. So, something very important if you missed, because you didn't ask me about any contraception, any treatment. I tried for regulating my cycles. I told you that I am going for some weight management, but it's not working with me. Then no pap smear history. If I ever got pregnant before, all these things, because you thought she's not married, so that chapter is closed. It is not like that in Ireland and UK exams. In any exam, European exam, you don't ask this question. Okay, so you will take a history. So when you are taking, her thing is BMI is what, 48. So with the BMI of 48, any person, even if not PCO patient, that patient is at increased risk of having cardiovascular disease, diabetes, and so many things. So you should, tell her that why weight management is very, very important. If you will take a history from me, I will give you history of hirsutism. I will give you history of sleep apnea. And I tried low dose oral contraceptive pills, but they made my weight more high. So I stopped them. And I'm just not concerned about weight reduction. And if I feel that because I feel that weight is not a problem. Even my mother is big, my sister is big, and I work as a prison guard. So, I need to be big in front of the prisoners. So this is my thought. So I have to be, the counseling part in this station is very, very important. It might come as a 10-minute station where you just have to counsel the patient. It came one time that the patient want to know about the long-term effects of PCO. No fertility was required there, no treatment of fertility, only the long-term effects. And there you have to explain these things in detail. So what is the primary? You have to talk about the risk of diabetes. So patient needs annual screening with HbA1c. There is increased risk of cardiovascular disease. She has to do weight management. She might be already suffering from sleep apnea. So you have to, send the patient to the physician for the treatment of sleep apnea. Then in pregnancy, she's at increased risk of gestational diabetes, high blood pressure, preeclampsia, and a miscarriage. And then she might be suffering already from emotional disturbance, like maybe because people who are big, they either sleep all the time, they don't have a social life, so they feel very aloof and alone. So she might be suffering from this anxiety, depression. So you have to exclude all these things in a patient with PCO. Then if she's having hirsutism, of course, the baseline of PCO management with the patient with high BMI is weight loss. Then you will go to the oral contraceptive pills, which can be of different types. And then there can be, temporary, she can go for waxing, depilatory things, or laser for hair removal. And then if there's acne, weight loss, and this OCPs, they will help her acne as well. And if it's not helping, then you will refer the patient to the dermatologist. And for fertility, this patient will be started on metformin or later letrozole. So basically, they expect you to cover everything in this station. Okay?
Okay, doctor, but the sleep apnea, it was not in the complaint actually. It was only that she's with BMI 48, she's 32 years of age and irregular periods for a long time.
Yeah, this is what I'm telling you, that in RCPI, they will not give you everything in the station written. You have to ask from patient. Is there anything else you are suffering from? Then I will tell you that, yes, I don't know, while in the duty, I just sleep. While sitting, I sleep. And in the night, I feel I cannot sleep properly. So I get up again and again in the night. Then I sleep at work.
Okay, and I will take, okay, doctor, and I will take history about her bowel and urinary complaints also.
That is normal. You can ask that if you have any bowel or bladder problem. If you have any problem with your water works, so she will tell you. If she has any urgency, frequency, dysuria, she will tell you.
Okay, doctor. Okay.
All right. Okay, so next slide, Zaib, please. Okay, so as we know, PCO, what is the PCO? It is defined as what? Yes, Nahi.
Polycystic ovarian syndrome. This is according to Rotterdam criteria, either no periods or amenorrhea or irregular cycles oligo. And this biochemical profile is showing this raised LH to FSH ratio, reversed and raised, and signs of hyperandrogenism, including the hirsutism and acne.
What is Rotterdam criteria? If you say Rotterdam criteria, then simply say that. Don't go here and there. Okay. There is going to be menstrual disturbances, simple, biochemical or clinical hyperandrogenism. Okay. Then there is going to be what? The third thing, anovulation, oligo or anovulation. Okay. So this is how it goes. The three things: biochemical or clinical hyperandrogenism. It doesn't necessarily mean that every patient will have hirsutism, acne, or anything. Okay. So then you will make a diagnosis on the basis of Rotterdam criteria. For every woman, there is going to be the 2 out of 3 For younger adolescent age group, there is going to be 3 out of 3. Okay, so this is how you speak in the structured discussion. Like Dr. Uzma was asking you, so you have to be quick that okay, I have to diagnose this on the basis of this, then I have to diagnose, then I have to induce her. If at all she is going for infertility, so I'll do this. If at all she is going for this, then I will do this. Okay, I'm sure everybody knows, but the problem is practice. Okay, the problem is because we have all been studying this PCOS for our the whole life. The problem is how we are going to put our knowledge into this station. Okay, this was my exam station as well, so it was very beautiful station. Yes, Dr. Uzma.
Yeah. Okay. So Shumaila already spoke about the symptoms and the endocrinology, and then what is the possible lead sequel is that the patient can have diabetes, patient can have dyslipidemia, high blood pressure, cardiovascular disease, and patient can have endometrial cancer. If she is not bleeding, so this is very important patient safety factor. If the patient is giving you a history that I don't have periods for past 6 months, so she is at a risk of, any PCO patient who is not bleeding regularly is at a risk of CA endometrium. So she should bleed every 3 months. You should give her a withdrawal bleeding. You should give her a progesterone. So they are looking at your applied knowledge. You have to tell the patient that it is very important that there is a increased chance of you. If you don't have regular periods, then at least every 3 months, you should have some withdrawal bleeding. So you should take this medicine. Okay. All right, then you should perform a glucose tolerance test for the patient. How you this patient, all the investigations I already wrote. So like you will go for a pelvic scan and you will do serum testosterone and estradiol, LH, FSH, prolactin, thyroid function, fasting insulin, and oral glucose tolerance test. Then patient is obese. So first line is lifestyle modification, send her to dietitian, tell her to exercise regularly. And then if this is not helping, either she can take medical treatment, which is like orlistat she can take, metformin you can prescribe for her. Or if this is not working, then she can go for a surgical management, that is gastric bypass, gastric sleeve she can do. Okay. Her menstruation, you will regulate with the help of the contraceptive pills, the combined contraceptive pills, low dose pills you will start for her. And once she wants to get pregnant, that time you will induce ovulation with anti-estrogens and either clomiphene citrate or letrozole. Okay. Then if the patient, her hyperandrogenism, as I told you that physical methods of hair removal can be used like electrolysis, laser treatment. These oral contraceptive pills, they also help in hair reduction. You should add this progesterone, which is ethinyl estradiol and cyproterone acetate. But this cyproterone acetate is recently linked with high risk of DVT. So it is withdrawn from the market, at least from UA market. We cannot prescribe it. There are other types of progesterone which are available in combination, which you can prescribe to the patient. This helps in reducing the androgen levels. And then when you will refer this patient, if you see a very high level of testosterone, where you are suspecting that there is some testosterone secreting tumor, so that patient you will refer. Okay. Or you see there is signs of virilization or hirsutism is rapidly increasing, the patient is uncontrolled diabetes, and the amenorrhea is for very long. From this time, the patient will go from GP to the specialist, a specialist who specializes in this field. Such patients, when they get pregnant, they are at increased risk of having high blood pressure, preeclampsia, diabetes, and miscarriage. This concludes your station. Okay, any questions about the long station now? No questions? Everything is clear?
Doctor, can I ask a question, please?
Yes, sure.
Alaikum. That's the question I want to ask, because patients' body mass index is so high, extreme obesity. In such condition, if I want to regulate her cycle, better to avoid COC? and use the progesterone rather than COC?
Yeah, you can do that.
Yeah,
You have
because-
both options. She is very obese, so you feel OCPs will not be, suitable choice for her. So you can give her a progesterone in the second half of the cycle, or after every 3 months, you can make her bleed with the progesterone challenge test. Yeah.
yeah, especially the last generation of COC that you mentioned it in hirsutism and acne, it's increased risk of DVT. So it's possible to avoid this during counseling.
Yeah, you're right, Anna.
Oh, okay, thanks.
Welcome. Okay, I think we'll go to the next task by Dr. Zaib. It will be a 10 minutes task, OSCE station, and anybody wants to take the task?
Excuse me, doctor. I want to
Yes.
ask one question regarding her personal, this family history of ops history. I will ask that. Okay, if I will not ask that you are married or not, but how I will ask about kids parity.
Have you
if
been
it is
pregnant before?
Okay, so when I will ask this question after complete description of presenting complaint.
Yeah, once you see, this is a gynae case, right? So first you will ask her about her presenting complaint, then you will go for the history of presenting complaint, then you will exclude the menstrual history first, and then you will come to the obstetric history. You will ask, have you been pregnant before? She will say no. Okay, so are you sexually active? Yes. So are you using any contraception? Like that, okay?
All right. And in the end, I will mention that are you living with your partner?
No.
Whom you are living with?
You are living who you are living with. She
Who
will
you are
tell
living
you who
with.
she is living with, okay? Her partner, her parents, alone, whatever. Once she says, I live with my partner or my husband or my boyfriend, then you will say, is he supportive?
All right. And the smears, when I'm supposed to ask about cervical smears, are they up to date? When I will ask after complete history, after finishing the history?
In a gynae history, once you are taking the menstrual history, same time once you finish your menstrual history, you will ask about the pap smear, okay?
Okay, doctor. Thank you.
Welcome. Okay. Yes, Zaib.
Okay, very good. So who wants to do the OSCE station with me? This is going to be a 10 minutes station, complete 10 minutes station. Okay, here is, the one of the difference in the Irish OSCE and the MRCOG. Okay, in MRCOG you have 2 minutes reading time and 10 minutes performance time. In Irish, you will have total 10 minutes time. Okay, so you have to read question and you have to start it. Nobody is going to ask you that, okay, you have to start. Once you will be done with your one OSCE station in 10 minutes time, then you will move to the next station. Okay, so who wants to present? But the theme is same for MRCOG and the MRCPI. Okay, so I think nobody is interested. Yes, Martin.
Okay, let me try.
Okay, fine.
Okay, can I try?
Okay, let's see. Okay, you will have total 10 minutes, Martin, and your time starts now.
Okay. You are about to see a woman of 38 years. You are working as a trainee in urogynecology clinic, and the nurse has asked you to see a woman with some complaints of urgency and frequency. Please see her and formulate her management plan. She's scared of any operation on her. Discuss her the management options and alleviate her concerns. All right. Okay. Sorry, but is this a counseling session?
Well, yeah, it is a counseling station, OSCE station. Like you have to take history and you have to formulate the management in total 10 minutes.
All right.
Yeah.
Thank you, Ma. Okay. I am Martin and the candidate for this exam. Please, Ma, I would like to know what's your name?
Oh yeah, I'm Claire Thomas and I'm 38 years.
Okay. All right. So where do you work, or what do you do? What work do you do?
Yeah, I'm okay, doctor, but I was just having some problem with my waterworks, and because I have to go to the loo quite the frequently in daytime as well, and I have to get up at night as well. Plus, sometimes I feel that I have to rush to loo, and sometimes I wet myself as well. So this is really bothering me. So that's why I'm here to discuss that what exactly it is, and is it not something bad? And just to tell
Thank
you
you so
one thing,
much for the
doctor, I don't want any operation at all. Okay.
all right. Thank you so much. I would like to know, have you been pregnant before?
Yes, doctor, I have 3 kids.
Okay. They are all alive.
Yes, yes, yes.
Okay. Thank you. So when did this your problem start with your waterworks?
It's been like, doctor, 6 months.
Okay. All right. You said you have to rush to the toilet, and
Yes.
there's no associated anything coming down from your body or vagina.
No, doctor, no.
Okay. All right. Thank you. So when apart from that, do you have any other swelling in your stomach? Is your abdomen swollen?
No, doctor, no, nothing.
Okay. Do you experience pain while urinating?
Sorry.
I said, do you have pain while urinating, or do you?
No, no, no pain, doctor. No. I just have to rush. I have to go frequently. That's it.
Okay, and you don't urinate on yourself.
No.
All right. Thank you so much. Okay. Um. Okay. Do you have any discharge from your body? Any abnormal
No,
vaginal discharge?
no, no, no.
Okay. Have you had any surgery before?
No, doctor, just like small cuts at the time of childbirth. That's it.
Okay. Okay. All right. Do you have any medical condition? Are you hypertensive? Are you diabetic?
No, doctor, I'm generally fit and well.
Okay. Have you been admitted in the hospital before?
Oh, no, never.
All right. Thank you so much. Do you react to any medication?
Not as such.
Okay. What have you done for this your condition? Have you been to any hospital before? Have you taken any drug?
No, no, doctor, this is my first consult. So that's why I was very worried that what exactly it is.
All right. Thank you so much. All right. Okay. All right. All right. Thank you. Um, I
Now
think
you
I'm
have to
done with
tell
the
her,
history taking.
no problem. Now you have to tell her that what probable diagnosis is and how you can help her with. What do you think the diagnosis is, Martin? Urgency,
Okay.
frequency, okay? And she is
Yeah.
coming to the urgency, frequency, and sometimes there is incontinence as well. So what does it make? Symptom
Okay.
complex of
I think
OAB,
yes.
isn't
She
it?
has a stress.
OAB,
She has
stress means stress when she is
a
leaking on cough.
stress.
She's not leaking on cough, yeah?
She's not leaking, so it's urgency.
Urgency, frequency, and sometimes incontinence because she's wetting herself at times. Okay, so this is going to be the clinical spectrum of
This.
overactive bladder. So in
Uh,
terms of overactive bladder, how you are going to ask her about the overactive bladder? What do you want to know in overactive bladder in history? You want to know her drinking habits, isn't it? You want to know that how much fluid intake do you have, in terms of water, coffee, cola, any soda, okay, alcohol, anything. So you have to inquire about that, isn't it? So then you are
yes.
going to ask her about that. Do you know what your BMI is? Because BMI is important. Do you remember from the incontinence guideline that even in overactive bladder, mixed incontinence, and even in the stress incontinence, we have to ask about all these, the basic questions, isn't it? So you will ask her, all these things. So if she will tell you that, yes, doctor, I take almost 6 to 7 cups of coffee in a day. So now you have the idea that why she is going, so many, the frequency, why she's having this frequency, why she is having urgency. She is taking 6 to 7 cups of coffee in a day. So coffee is what? Weak diuretic, isn't it?
Yes.
So that's why,
Yes.
This is one of the reason. And then of course, first, what is the first line, the management of overactive bladder? So after taking history, what you will tell her that, okay, Claire, thank you so much for giving me this information. So regarding this, what I understand is that you are having a condition, what we call it as overactive bladder. Have you ever heard about it? No, doctor, no, I have never heard about it. Okay, so let me tell you, as name says that overactive bladder. Okay, so usually what happens is that bladder is under control. Okay, and bladder is under control of the brain, and uh, whenever the bladder stores some of the amount of the urine, so what happens is that when the bladder muscle is relaxed, as the bladder gradually fills up, as the bladder gradually stretches, we get a feeling of wanting to pass urine when the bladder is about half full. And sometimes we can I mean even don't want to go to the loo until we have any the facility to go to. Okay, so what happens is that when we feel that it is convenient for us to go, but however, in people with overactive bladder, what happens is that bladder muscle seems to give wrong messages to the brain, that bladder may feel fuller than it actually is. Okay, so Claire, in this, the what I feel is that what I have gathered from your history, that you are having urgency, and this overactive bladder is having the symptom complex of urgency. Urgency means which is sudden compelling desire to urinate. Frequency, when you have to go to the loo more than 8 times a day and more than 2 times at night. Plus minus incontinence means the leaking of urine. Okay, like you said that you wet yourself quite sometimes. So altogether, this makes a diagnosis of overactive bladder. Am I clear so far, Claire? Are you with me?
Thank you. Yes,
Okay,
I'm
so
with you.
Martin,
Thank you so much.
so she will ask you this. You will ask her in the history, and then you will say, okay, Claire. Then in terms of management, let me tell you that some general lifestyle measures may help. Like I can see that you drink coffee a lot and you take alcohol after 6 p.m. as well. So what happens is that usually caffeine and alcohol both irritate the bladder lining and it makes more urine as well. That's why you are facing such problems. So it's better if you cut down your coffee intake and don't drink alcohol after like 6 p.m. So by this, what will happen is that you can sleep the little better at night, and plus you will be very the you will not have this frequency in the daytime as well. So what do you think, Claire? Can you do that? Yes, doctor, I will do that. And the second thing is bladder retraining. In bladder retraining, the main treatment in which the what we ask is that you will train your bladder to hold the urine for quite some time. Okay, despite the bladder asks you to go to the loo, you will train your bladder to when to go to the loo. Okay, am I clear? So together this, Claire, what you will do is that you will be doing this for like quite some time. Okay, say like 3 months, and usually it works well in half of the cases. Okay, so with bladder training and the lifestyle measures, that you will cut down your coffee and this alcohol, so it will help you a lot. So if it doesn't work, so then we will start you with the medications. So medications are for the first line, and we do have the antimuscarinic agents. Okay, antimuscarinic or anticholinergic means that we are going to block the signals to the brain, from the brain, which are coming to the bladder and which are asking us to go to the loo. So, but and we do have the couple of categories for that, the first line, second line, third line, and after 3 failed drugs we will switch to the another special drug. Okay, so in this we do have oxybutylene, tolterodine, trospium, propionine, solifenacin. So almost all these drugs do we have. So it will do what? It will work by relaxing the bladder muscle, and so what will happen is that in the end it will increase the bladder capacity. Okay, Claire, are you with me? Yes, doctor, I'm with you. Okay, fine. So medications will improve symptoms in some cases, but not in all. Sometimes, the improvement will vary from person to person. And secondly, what happens is that, these because these are blocking the signals which are coming from brain, and the same signals are, the nerve fibers, I must say, that they are coming and they are supplying to the eye, to the the mouth, which is making saliva, eye which is making tears, the gut which is the making helping in the stool softening. So what will happen is that the all these signals will be the blocked altogether. So you will face sometimes the dry mouth, constipation, and blurring of vision. Sometimes these side effects are like very minor, and they can get settled with the passage of time, and usually it takes 4 to 6 weeks for every drug or every medication to work. If it doesn't work well, then we can switch you to the the patches as well. All right, So, these are all options, Claire. And after this medication fails, then, we can move on to the special third drug, what we call it as mirabegron. And if it doesn't work, then we can move to the, injections in the bladder wall to relax the bladder muscle, what we call it as Botox. So let's take things, the one by one. And does it, the Claire, to you, Claire, is it okay that do you want me to repeat anything? So doctor, if at all I have to go for surgery, then what will happen? So before taking any woman to the surgery, these Botox injections are form of, the operation, okay? Because we'll be doing it through the help of cystoscope. So that is going to be, the special instrument by which we are going to inject the Botox into the bladder wall, okay? And if that doesn't work, then, we can move to the some of the the application of the batteries, and that one can be fixed to your the sacrum onto the lower back, and one can be fixed on the the ankle, okay? So we call it as sacral nerve stimulation and posterior tibial nerve stimulation. And after that, if it doesn't work, then we can go and then we can think of the major operative procedure. But usually, all these medications, lifestyle measures, and these Botox injections work well in the women having this overactive bladder. Okay. Okay. So, Martin, is it clear to you now?
It's clearer to me now. Thank you so much.
Okay. So my dear, this is how we, take history. So your history was okay. You did try. But our history should be very focused as well. Okay, now let me tell you. First, you have to greet. You have to make a rapport. Always remember, you have to make a rapport. If it is morning time, if it is afternoon time, so you will at least, because this is not something, the bad station. So you will say, hello, good morning. I'm Dr. Martin, one of the doctor in the urogynecology clinic. So can I cross check the name and age, please? Yes, I'm Claire Thomas and I'm 38 years. Okay, well, nice to see you, Claire. Nice to see you, doctor. So I see that you are having some problem with the water work. Am I right? Because on the question it is written that she is having problem with urgency and frequency. So altogether, the bladder and the problem with the bladder and the urine or something, we call it as water work. Okay, so everybody, so you should know that we call it as water work. So I can understand, Claire, that you have some problem with your water work. Am I right? So yes, doctor. So she will start, telling you that I'm him. Okay, let her speak. Gather your, the desire that what exactly do you want to know about it. Okay, fine, fine. So how many times do you need to go to loo? It's better say loo, and day and night. Do you need to rush to loo? Do you ever leak or wet yourself? So if she's telling you herself, so you can, just skip this question. Do you have any bloods or any pain while you pee, any stinging or burning while you pee? So this will show what? This will show your UTI. Okay, so it means you are excluding each and everything according to the NICE guideline. In every incontinent or in every all these women, you have to exclude UTI. You have to exclude, the diabetes as well, which can be the reason for, such symptoms, frequency, urgency, and all. Then you will ask her that, can you please tell me about your drinking habits? Approximately how many bottles of water, cups of coffee do you take, especially in daytime and night, and especially after 6 p.m. And how is it affecting your life or your sex life? Yes, doctor, it is affecting me badly. I work as a teacher, and because of this, because I have to go to the loo all the time, so I can't even concentrate in my class. Yes, yes, Claire, I understand. It must be very bad. See, you have to acknowledge their pain. You have to acknowledge their suffering as well at the same time. Not in so many words, but of course, you are going to tell her that it is quite understandable. It must be very, the tough on you. It must be very bad that you have to manage this and that. All right. So then you will ask that, have you tried anything so far? Any associated bowel problem? Do you feel something coming down in your vagina? At the same time, you are asking about UV prolapse. Are your smears normal and up to date? And then how about your periods? Are they normal? Do you smoke? Do you drink alcohol or take any recreational drugs? No, doctor, I don't smoke, but I drink alcohol. And this is kind of a ritual in our family to have, the alcohol after 6 p.m. every dinner time. Okay, okay, all right. So now you have idea that why she's having frequency urgency. She's taking alcohol. She's taking, the 6 to 7 cups of coffee. So from history, you will gather your, the management points as well. Whom do you live with? Is everything okay at home? So, then you are going to, to talk about the management, what I have told you. Martin, is it clear now?
Yes, it's clear. Thank you so much.
Okay, okay, very good. That
Doctor.
was very brave of you to come forward and at least try. Okay, this is how we learn. See, all of you guys remember, nobody was master, I was not even master when I started off my preparation. I still remember when I started off my preparation, my first session was for about total, I think 21 or 22 minutes. But of course, with the passage of time, with the passage of, the learning, improving, and, the everything. So now it is very easy for all of us, who are in this, because me, Dr. Uzma, and whoever who is mentor today. So of course, once we were student as well. So don't think that it was very the easy on us as well. We literally worked hard. We literally worked very hard for all these exams. Okay, so it's not easy. Practice, and you just have to practice, and that's it. Okay, clear everyone? Any question? Any question, guys?
Assalamu alaikum, Doctor.
Walaikum assalam.
Doctor, I want to ask if it is simulated patient task, we can talk in lay examiner language.
Yes,
But
you have to.
yes, sometimes I have the expression, but I cannot tell. So what I will do? Really, I have a block. Really, sometimes like I have block. I cannot talk more or like this, but I have the information in my mind, but I cannot express my thoughts to the patient. So do you have any advice for me just to do this one?
Just practice, sweetheart. Practice will make you perfect. That's it. Okay. So this is how
Okay.
we learn, yeah, only there is no other way. Because of course, sometimes many people, they are not so much expressive. But the thing is, you have to simulate. You have to, just, simulate. This is just going to be, the practice of, how good actor you are, and that's it. The way you will act in this exam is going to show it to the examiner that okay, you are good to fit in the system. That's it.
I will try. The problem I'm trying in front of my mirror. So the one who see me is me. So understanding me, but not others. I want to practice more.
Yes,
Really,
you
I
have to
need
practice
practice
more.
more.
You can practice it with your study buddy. You can join us. We can train you. That's why the courses are there to help you guys. Because we do try to give the equal attention to all our candidates. We try to pick their good points, their the weak points. We give them tips that okay, you have to mold your, because sometimes like you yourself said that for the Breaking Bad news. So of course in Breaking Bad news you are not going to be the very the your face expression should not be very the kind of what I can say, the flat. It should
Yeah.
show some kind of the emotions that you are feeling bad. Okay, like I
Yeah.
mean, for example, if you have to tell somebody that this is cancer, so of course you have to give her some warning shots, that you are going to tell her some bad news, and then you are going to tell that I'm so sorry that I
Yeah.
don't have a very good news for you. Okay, but it should show from your face, it should show from your emotions, your expressions, your tone, your pace, your words. Okay, so this is how we go for.
Okay. Thank you.
Okay, sweetheart.
I want to ask more question. Is there
Yes, sure.
any course now available in
MRCPI, yes. Me and Dr. Uzma, we both are starting a course. The quite. I think this is September. By the end of September, inshallah.
at the end of September?
Yes, September. By the
Okay.
time you guys will have your confirmation as well, because sometimes what happens is that candidates, they do join, and then what happens is that when they don't get seats, so they get lazy, they don't come in sessions, they don't take classes. So we really wish and we really hope that let me be the very repetitive on this thing. Don't take this exam so light. Okay, so every exam is difficult. Every exam has its own the preparatory techniques. So we should be very much prepared. So for this course, yes, we are going to start our course very soon, inshallah. And also we are offering the mocks as well. So you guys can book mock with Dr. Uzma, you guys can book the mocks with me as well, or both of us. So I mean, we will be very happy to help you guys, that okay, this is how exam works. Because for me, I'm an MRCP examiner as well, and recently I passed my MRCPI as well, Dr. Uzma too. So Dr. Uzma is the senior mentor for the MRCPI. So of course we can guide you well, so don't worry about it.
Inshallah.
Inshallah. His offering will be 1 day practice. See, sweetheart Yasmin, 1 day practice is for mocks. Okay, 1 day practice is always mock. Mock is like, the exam like rehearsal. That's why it is termed as mock. So mock will be for one day only, until unless you do try to take, the 1 or 2 mocks. Okay. But the course will always will be spanned on like few weeks, 6 to 8 weeks. Okay. And in that we are going to try to cover the all curriculum. We do try to finish the long cases, the hot favorite, the exam scenarios in terms of OSCEs, in terms of long cases as well. So of course we will try to help you guys. Okay. Mock exam. Okay. Yasmin, let me ask one of my team member to help you. Okay. So she will guide you through. Okay. So I can see Ramesh. If you are there, please facilitate Yasmin. Okay, very good. So I know that because this is a kind of, the many people, almost everyone is, the inclined towards MRCOG. And but if somebody is very much focused for MRCPI, so take MRCPI as MRCOG as well. Because since the MRCPI is recognized as GMC equivalent for the MRCPI for GMC, okay. So I think this is a very good chance that you can, do MRCPI, and then you can go to the UK, or even you can go to Ireland as well if you want to. But otherwise, this is trust me, additional qualification is never bad, even if you are consultant in your own, the respective countries. So this is going to be helpful. I am all into education, so I really, they appreciate if somebody is going for, the additional qualification exam. So this is very good. So go for it. Okay. Any question? Any question? Any question, guys? Any other question? We can help you with any query regarding exam, regarding its pattern or something. Hmm?
Excuse me, ma'am. I would like to ask a question.
Mm-hmm.
I just want to know if there's any course in which we can do practice, hands-on practice on the mannequins.
Sweetheart, hands-on practice for online courses is not, the possible. And well, you can look and you can book in your locality where you are based. So because so far, up to my knowledge, nobody is offering, the on site, the courses. Okay. For this, for this, okay, Dr. Uzma, let me.
It's okay, done.
your system is ditching you today.
I'm talking. I'm not. Nobody can hear me. Actually, I'm muted myself.
so just let me finish this answer, then you can take over. So Rabia, I was just telling you that nobody is going to give you as such the hands-on practice. But sweetheart, if you are in any the hospital or any setup, or even you can go to the any teaching hospital. So almost every teaching hospital in every country, they do have mannequins. Okay. So you can, request the respective, the person who is dealing with this mannequin, and usually those are ward clerics. So I think you can go and you can just, simply, and you can ask someone to, the see, or if you are in Pakistan, I will advise you. In October, there is FCPS, the long case. Okay. So you can book FCPS, the talks course, or any long, the short course. So I think that will be helpful. Any MCPS, the preparatory course, any FCPS or any IMM preparatory course, that will help you. Okay.
Thank you, ma'am. Thank you.
Okay, sweetheart. Okay. Yes, Dr. Uzma.
Yeah, okay. Sorry, actually, I was just asking for Rabia whatever question she has to ask, and is it already answered?
Yes, it is answered.
Okay, all right. So we have successfully completed already 2 courses, and alhamdulillah, our result was 100%. All my students, they passed in their first attempt. So I am already doing 1:1 session, and we'll soon be starting, as Zaib informed you, after maybe last end of September, a course. If you people want to join this course, we will be doing, I think, 6 sessions. And in each session, we'll be doing long cases and short cases. All the topics will be from the previous exams. So it will be a very good opportunity for all of you to, come participate, because unless you perform the station, you will not know where you stand. So listening to others and like only some people, they join as listener, it is really not beneficial at all. You should be active participant of whatever group you want to join, whichever course you want to join. Please join as an active participant and participate actively. Here in the session, you can make any mistake you want and we will correct you. Unless you speak and perform, we will not know where you stand. Okay. So my students, alhamdulillah, they've all passed with very good, great marks, and they were very confident before going to exam. So I'm not just saying that you come and join our course, but whatever course you join, please participate actively in that. Okay. Yeah, we'll be starting by end of the September. We'll give you the our schedule soon, inshallah. Tohana.
Yes.
Oh, so doctor, can you send the link for the
Joining
course?
the course? Okay, okay,
Yes.
sure.
Okay,
Okay,
we,
sure.
we really, I'm waiting for this date. Just so I want to participate with you.
Okay, okay, sure, sure.
Inshallah, don't worry.
I have another question. In MRCPI written exam, we have this Irish guidelines in the top. We studied more. And this OSCE, only Irish guidelines or this green top guidelines and nice guidelines we have to practice.
Basically, everything is mostly the Irish guidelines. The updated ones are almost same as the RCOG guidelines. Okay, there's hardly any difference. Only the herpes, what they are following, herpes in pregnancy, that is different from RCOG. Because they want to do cesarean section where RCOG says recurrent herpes, or if you contracted in first trimester of pregnancy, then patient can go for a vaginal delivery. But RCPI says, no, you go for a cesarean section. Other than that, most of the guidelines are the same. So I would suggest you follow the updated guidelines from the RCPI, okay? But the ones who are like 10 years old or 15 years old, just follow the RCOG for that. Because even the examiner is following the RCOG.
The RCOG.
Okay.
Thank you, doctor. Thank you.
No problem. Any more questions? All right, I think we are clear. So
yes, thank you so much, guys, for your participation. Thank you so much, Myla, Martin. Okay, being the courageous enough to come forward and practice. And Shmaila, don't feel bad, okay, sweetheart. So with the passage of time, like I said earlier, nobody was master. Once the started. I when I practiced my first OSCE station, I took exactly 22 minutes. I still remember. Okay, so don't worry about it. And still, I'm little bit, so much poor in many stations. Dr. Uzma knows that. So whenever we the speak, I always say, please, you will take this session. I will not take this station. So not everybody is perfect. Okay, everybody has the weaknesses, some strengths. So try to use your strengths more rather than show your weaknesses. Okay. I can say, Shmaila, you are very confident, and I think you can learn quite quickly. Okay, so just stay focused, just study a little bit more, just practice, and inshallah you will do. And Martin is my own candidate. If he will come to me, I will definitely groom him.
Ma'am, there's one more thing I want to ask, please.
Thank you.
yes, Rabia, go ahead.
Ma'am, in the OSCE exam format, the date is written TBC. What does that
confirmed? To be confirmed.
Okay. Thank you.
Okay, no problem. Okay, the thing is, it is only practice which makes you perfect. Only God is perfect. We all are learning, even after passing all the exams. We learn every day. We learn from even the participants, how they perform, how they say certain things to patients. So, everybody is always learning till we die. So don't think that everybody is perfect and you cannot do it. It's very brave of you, both Shmaila and Martin, that you came forward and you tried to attend the station. And this is the courage we expect from all of you. Unless you are brave enough to come forward and speak, believe you me, in the exam day, you will be, very shy and very hesitant to talk. So talk, right or wrong, talk. Initially, you might be wrong, but later you will become perfect. Okay?
Exactly. Okay, guys, thank you so much.
Thank you very much, everyone.
Yes. So for any course detail, any mocks, so our team will help you. Okay. So we do have Ramesh, our MRCPI candidate, Anam, okay, so they can help you with any query there is, all right? Or even, me and Dr. Uzma, we are also easily accessible. So do talk to us. We are present on Facebook, on WhatsApp, on Telegram. So chase us